Hello, I'm Dr. Sherman Silber, and I want to thank you all for joining me on Facebook Live. What we periodically do is try to answer questions live that various people will have brought up in the interim, and I want to answer everything I can that you bring up to me about what's the newest infertility treatment, and what are the myths, what are really the things that don't work, what are the things that do work, and answer any questions about this. It's very controversial, and many couples are mixed up about how to handle it. So I'm here to answer your questions, and questions that you've sent in over the last month or so, and we'll answer more questions in the future.
Thank you, Dr. Silber. The first question from the audience is, what if we are not ready to try IVF? What can we do to increase our chances of getting pregnant?
So this is a lot of couples really are concerned and worried about going into technology like IVF and that expense. And frankly, if they're younger, it's a good idea to maximize your chance of getting pregnant without having to go through any kind of fancy treatment. So what they usually do, which is a mistake, is they go to the pharmacy and they buy an ovulation kit, Clear Blue Easy being an example, and they try to hold off intercourse until they predict they're going to ovulate and then suddenly have their intercourse. And this is actually a poor idea. It's a myth. First place, after your eggs are ovulated, they're only really good for about 2 hours, maximum 8 hours, but probably 2 hours is their best shot. And so you always want to have sperm there when you ovulate. And you're not going to get it right if you go by trying to predict your ovulation time. I mean, you'll be a day off or 2 days off, or even if you're just 8 hours off, you're clearly not going to get pregnant from that. So the best approach, if you are young enough that we're not worried about your eggs getting older, then the best approach is actually to always have sperm present there. Now, the sperm will live for about 2 or 3 days in the female tract after intercourse. So intercourse 3 times a week is a much better approach, much better strategy than not having intercourse and trying to figure out exactly when you ovulate.
So how long should you go, or when should you start to consider assisted reproduction or IVF?
So really, when do you really take that, what will seem like an extreme step towards IVF? Well, the standard answer for that really is if you've gone for 1 year of unprotected intercourse and you're still not getting pregnant, then it's time to go to IVF. There may be some doctors or clinics that recommend IUI, that's intrauterine insemination, or may recommend just going on different drugs to stimulate ovulation. But frankly, after 1 year of trying, it's usually your best strategy is to go to IVF. Even IUI, insemination or timed intercourse, is not going to get it right. If you've been having regular intercourse and you're still not getting pregnant after a year, the usual recommendation is to go then to IVF. But what if you're 23 years old? Well, you've got all the time in the world. You can wait more than a year if you want. What if you're 37? You don't have any time at all because your eggs are getting old very fast. So it could be that if you're 37 and you're not getting pregnant right away, you really should seek counsel immediately, not wait for your eggs to become 38 or 39 or 40 years old.
Are there different types of IVF to consider?
So the question is different types of IVF. Well, there really are. We can divide the actual laboratory work into conventional, where you just put the sperm in with the egg, or IFC, where you inject an individual sperm into an individual egg. We will do IFC with all of our cycles and not charge extra for it because we think in the modern era, if you know what you're doing, every cycle should be an IFC cycle, and you shouldn't take a chance with failed fertilization, and we won't hurt the eggs. In fact, we'll get a higher fertilization rate with IFC than we will just with standard insemination. But the other different approach is how you stimulate to get eggs. There's conventional stimulation where you get pounded with hormones, and you really, it's pretty miserable, 300 or 400 shots per cycle, hormonal swings, enormous expense, and the doctors may be trying to get 20, 30, or 40 eggs. And most of those eggs are poor quality when you do it that way. When you overstimulate, you get worse eggs. The other approach is what I just call mini IVF, and all that means is mild stimulation. Innovative ways of stimulating you mildly. It's more pleasant, that's true. It's less expensive, that's true. But that's not really what we're aiming at. What we're aiming at is 5 times higher live baby rate per egg. Not a little statistically significant difference, but a 5 times higher live baby rate per egg with a minimal stimulation than with pounding you with huge doses of drugs. So I think mini IVF is now a better approach for virtually any age patient.
How long is the IVF cycle, or mini IVF cycle?
Well, it's interesting. How long and how much time does it require? Well, first, you really should go, it's going to sound weird, birth control pills. We would put you on birth control pills to suppress the ovary so that when we stimulate you, we don't get a lot of poor quality, what we would call non-ovulated, mid-size, non-atretic follicles that just have old eggs that aren't going to be any good. So you're suppressed with birth control pills anywhere from 18 to 40 days, minimum of 18 days, maximum 40 days. And then we give you your stimulatory hormones. It'll be really, really low dose. We're either going to start you on Clomid, which is remarkably effective, and follow that up with a very tiny dose of FSH shots every other day. And the birth control pills might have been as long as 1.5 to 2 months, but then usually the hormone treatment for stimulation averages about 10 days. And you'd have to be in St. Louis probably for about 7 of those days if you're coming from out of town, because we have to monitor you with ultrasound and hormone levels every day, or at most every other day, so that we know precisely when your follicles are ready for triggering. And that is one of the secrets of IVF, is that we can make sure that the timing is perfect for the sperm and the egg. We retrieve the egg, and right away, by 2 hours, we've injected the sperm and the egg, and the timing is perfect. And that's one of the many reasons why IVF is more effective than conventional intercourse.
What if my husband and I have gone to the urologist, and the urologist said my husband doesn't have any sperm? Is IVF still possible, or what options are there?
Well, that's a great question, because it's heartbreaking when the couple, obviously the first thing they're going to get is a sperm count, semen analysis. And it's going to show 0 in about 1 out of 200 men. Absolutely, not just a low count, but 0. And so it would appear that the husband isn't making any sperm. But we actually originally did this research back in the 1990s. We discovered that 60% of these cases where you think there's no sperm production, there is a tiny amount of sperm production. Maybe we'll find 5 or 10 or 15 sperm. I'm not talking about 100,000 or 100 million sperm or 10 million sperm or 5 million sperm or 10,000 sperm or 1,000 sperm or 500 sperm or 100 sperm. 1 or 2 sperm or 5 or 10 sperm are literally all we need, because we can inject those into the egg and get a normal pregnancy rate, no different than if the sperm count was normal. That was, again, one of the really fantastic advances that we helped pioneer that really, really works. But so we can go to the testicle under local anesthesia. You need to do it microsurgically because you don't want to damage the testicle. You want to assure the terrified husband that we're not going to harm him in this area that is so scary to him. We'll do it microsurgically, doing no harm. And if we just find a couple of sperm, that's all we really need to fertilize your eggs. And 60% of the time we will be successful in that.
My husband was put on testosterone for low T. Does that actually help fertility?
I see that all the time. It's couples come in and they don't understand, and their doctor would say, well, I think we need to boost your testicles. We need to boost your testosterone. We're going to put you on testosterone. Now, generally, infertility doctors won't do that, but your general doctor might have that idea. Low T is becoming a common misdiagnosis. I'll explain it for a second, that we measure hormones by an immune test. And we couldn't do that before 1979 when Rosalind Yalow got the Nobel Prize for this. But every single hormone you make is a little bit different in every animal on the planet, except for one hormone, testosterone. So you do these assays by injecting, say, human estrogen into a rabbit and getting rabbit anti-human antibody. And that's the whole basis for measuring hormone levels we couldn't do before 1979. But testosterone is identical in every animal on the planet. Whether it's an insect or an elephant or a rabbit or a human, it doesn't matter what the animal is. I like to say this is the primordial, original hormone, testosterone, and it's absolutely chemically identical in all animals. So the assays are very inaccurate nowadays. They used to be accurate because you'd have to attach a foreign protein to it and then develop your antibodies. But it's all being automated now, and so the testosterone assays are notoriously inaccurate nowadays. So if I see a man say, well, I had low T, and the doctor, because I wasn't feeling good, I didn't have the energy, I just didn't feel that much libido, and I was a little depressed, and so my doctor measured the testosterone, it was low T, so he put me on testosterone. And that's ridiculous, because if you have a beard, and you have decent muscle mass, your testosterone level is going to be quite adequate. And if you're just feeling depressed, that's not because of low testosterone. So what happens is the testosterone inhibits your pituitary hormone secretion of FSH and LH, and it's like a male birth control pill. So you absolutely lower your sperm count to zero or close to zero. And it's going to take about 6 months being off the testosterone before you're going to have an adequate recovery of your sperm. So please don't go on testosterone if you're trying to get pregnant. It's for bodybuilding, and the actual diagnosis of low T as a correct diagnosis is really extremely rare. It's being made incorrectly all the time. Everybody's going on T. And the drug companies share some responsibility for this because they push it in the doctors' clinics. And so it's one of the real myths that's going on, incorrect myths going on in reproduction today.
I have put off having kids to pursue a career, but have maintained great health through long-distance running and other cardio activities, even recently completing a marathon at 40. Why am I not getting pregnant?
Well, okay, so that's one of the questions. So many women come in that are really healthy. I mean, they're thin. Their health is fantastic. They run marathons. They do bodybuilding, and they feel like they're going to live forever. And as a matter of fact, demographers nowadays will say that these women should have at least a 50% chance of being healthy until they're 100 years old. It's just amazing how much longer we're living and how our social life and our viewpoints are changing. So we don't think about trying to get pregnant often until we're 40 or 45, or even 35 is getting a bit old. The eggs are beginning to decline even by then. And so the reason you're not getting pregnant, even though you're 40 and just ran a marathon, is your eggs are getting older. So the incidence of infertility, if we define it very strictly as 1 year of not getting pregnant despite unprotected intercourse, the incidence of infertility in teenagers is about 0.2%, really remote. It's up to 2%. By the time you're in your early 30s, it's 20%. By the time you're 40, it's about 80, 90%. So you can't imagine that from your teenage years to your early 30s, there's a 100-fold decline in your fertility, at least if you define it by 1 year of unprotected intercourse with no pregnancy. So the two things are happening. The number of eggs is going down. You're losing about 1,000 every month, and it's really a low number usually by the time you're in your late 30s. But also, the live baby rate or pregnancy rate per egg is going down dramatically. And we did a study on this. We found the curve going like this and then really dramatically declining after age 35. So that's why there's an infertility epidemic all over the world, because our life patterns are changing, and I'm not criticizing that, because women can get their PhDs or have their careers or not have to marry the first guy and can actually make a proper life choice. So it's good, but there shouldn't be surprised that the fertility is dramatically going down, and that's why in this era it's just a incredible epidemic of infertility around the world.
Are there any new technologies or procedures to be aware of with IVF?
Well, there's a lot of new technologies being talked about, and many of them, I'll be really blunt about this, many of them are fraudulent. Putting women on metformin to make them more fertile is ridiculous. It's a drug that helps try for mild diabetics to avoid having to go on insulin-like drugs. And it makes glucose and potassium go intracellular, and it doesn't really do anything for your fertility, even though it's widely spread around as a myth that this will help your fertility and your ovulation. Women are being put on male hormone, believe it or not, DHEA. And they almost accept that that'll improve their eggs. It actually hurts the egg quality. Randomized control studies are showing these things are myths. But then there's also other technologies that at first seem very alluring, so-called PGS, genetic testing. Patients come in and say, of course you're genetically going to test those embryos, right? Well, if there's a single gene defect, like the couples are carriers of cystic fibrosis or Marfan syndrome or myotonic dystrophy or muscular dystrophy or any of those defects, yes, okay, we can biopsy the embryo, and if they've got some kind of terrible mutation, we don't have to transfer those embryos. We can just transfer the healthy embryos. This isn't designer babies. Can't do that. No one has any idea how to do it. We don't even know why your eyes are blue or why your hair is brown or why you're tall or why you're short. I mean, it's such a combination of 25,000 genes and different numerical amounts that even to understand diabetes, we know it's genetic, but we have no idea what the genes are. Same with high blood pressure and with Parkinson's disease. So these common diseases, we can't even identify the genes for that. So it's not designer babies, but we can eliminate diseases caused by mutations that the parents are carriers of. But if you think you can do overall genetic screening, that's a fraud. That is the companies that are doing it do a very good job of amplifying a single cell or 5 cells biopsied from an embryo and counting the chromosomes. That's all they're doing. The error rate is incredibly huge. It is anywhere from 5% to 40% reported in the literature. This isn't something I'm just saying, it's in the literature. There are those that are pushing it in a big way, and then there are those that are saying, look, we're transferring so-called abnormal embryos, have healthy babies that don't have any abnormalities whatsoever, and they're intelligent and brilliant. Because of several factors. One is there's an intrinsic defect in the technology of counting these chromosomes, but the other really is there's a process called mosaicism in embryos where there are cells that are euploid and cells that are aneuploid, cells that have a normal number of chromosomes, cells that don't. And normally the cells with a normal number of chromosomes outgrow the cells with an abnormal chromosomes. And so you can have easily a diagnosis of the embryo being abnormal when it really is a normal baby. Now, in a 25-year-old, maybe it doesn't matter if you lose some embryos because of a misdiagnosis. But an older woman, it really matters because that could be the embryo that would have been her baby. So you really have to counsel patients very well so they understand the limitations of this technology and not over-enthusiastically guarantee it. I mean, we've got 10 to 20 million babies in the world from IVF that are completely normal that have never had any kind of genetic testing. And if there really are an abnormal number of chromosomes, usually they don't get pregnant. So we get a 60% pregnancy rate with every embryo transfer in women 37 or under. And control studies that did the genetic testing don't show any higher live baby rate than that. So it's really a good idea for older women in which it ruins some of the embryos and lowers the pregnancy rate. So it's a bad idea, and it's a really good idea for young women who don't really need it. So that is my humorous anecdote about it. So we're great. We wrote the original papers on New England Journal of Medicine and on this testing and fertility and sterility papers. We were doing this in the 90s, and we still do it, and we're good at it, and we know how to do it. And we wrote so many papers on this, so we understand the subject well. but you've got to really know whether it's good for you or not good for you. So that's one of the things. Also, just the idea of time-lapse imaging. This is a technology that was really pushed hard as a way of selecting embryos that are more likely to result in a pregnancy. And it really doesn't. It doesn't do any good at all any more than just checking the embryo's morphology at day 3 and day 5 and day 6. Oh, there are testing of the sperm that is really ridiculous. DNA sperm fragmentation tests. We know that at least 30%, 50% of your sperm are going to be old sperm, and they're going to have senescence, and they'll never result in a pregnancy. Now they call it DNA sperm fragmentation because people can charge $500 or $1,000 for it. But we were doing this in the 60s with electron microscopy, and we know that there are many sperm in any man's ejaculate that are going to have DNA fragmentation because they died of old age. Oh, I could go on and on. So there is a lot of so-called new technologies that are really baloney, and there are technologies we developed that are fantastic, like flash freezing, vitrification of eggs. We brought that to the United States. We were the first to bring it here, and we can freeze eggs successfully now. We can freeze embryos with virtually no damage whatsoever, like 99.9% success. So it allows us tremendous versatility in IVF, and we brought that vitrification here in 2003, and it's revolutionized IVF. And IFC, which we did in 1992, revolutionized IVF for male factor fertility. Sperm retrieval from the testes, which I hope the men aren't too afraid of, revolutionized IVF for male factor infertility. So there are a lot of new, fantastic things. Maybe I've gone too long, but maybe you want to know what's the newest thing we're working on now?
Absolutely.
Okay, so we're not going to be able to transfer these embryos that would develop from these right away because there has to be 5 or 10 years of safety testing. But we found in the mouse that we can take a skin biopsy in a woman that has, say, no eggs, and turn those skin cells into stem cells easily. Turn those stem cells then into germ cells. And then in the mouse, we have turned those germ cells into eggs that are fertilized with sperm, results in normal, healthy baby mice. Those baby mice grow up and they're fertile, and then they have baby mice. So we completely cure and solve the problem of no sperm, at least in the mouse, by taking a skin biopsy, even if there are no eggs. Now we're starting to do that in the human. Skin biopsies in women that don't have any eggs, and we're turning them into stem cells. And we've got a big grant and a big protocol for doing this study. I've never been motivated by trying to sell something. I have no patents. I could have lots of patents, but I don't bother with that. And in fact, technically, you can't have patents for procedures. You can have the patent, but you can't get a licensing fee unless you're selling some kind of product. And so we're not interested in something new and fantastic so that we can sell a product. But what we are really excited about is changing the game, being a game changer for women who don't have eggs. And this should work for men who don't have sperm also, though it'll be more difficult, and we're going to be starting to work on those men also.
Excellent. So last question. We're getting conflicted perspectives from different urologists. Can you talk a little bit about male infertility and maybe even point to some resources that would help us better understand?
Well, okay. I'm glad you asked that. My textbook on the fundamentals of male infertility just came out, published by Springer, which is a great medical textbook publisher. And I really do clear up all the myths, and I talk about what works and what doesn't work. Because I've been really doing male infertility. I think I'm the oldest, longest surviving, currently practicing male fertility doctor in the whole world. And we started doing with the microsurgical vasectomy reversals in 1970 at the University of Michigan, and then followed through at University of Melbourne, and now in St. Louis, Missouri for the last 43 years. And that led to a complete new level of research in male infertility. And all of our randomized control studies show that operating for varicocele, varicocelectomy, which many urologists still push, absolutely does nothing to improve the sperm count, and it can even have complications. So it's completely stupid to operate on a varicocele. 15% of men have big varicoceles, about 40% of men have small varicoceles, and it doesn't do anything to hurt their fertility. It just doesn't. So varicocelectomy doesn't help. The studies that imply that it does are non-controlled studies, but control studies show that it doesn't do anything. So that's a total myth. Putting men on hormones like Clomid to try to improve their sperm count doesn't work. The sperm production rate, the sperm count, is genetically determined. And we did all the original research on that going back to 1992 with the Y chromosome and the X chromosome. And we are sure now that unless it's a very rare phenomenon of what we call Kallmann syndrome or hypokinetic hypopituitarism, unless it's one of those very rare phenomena, giving the men these hormones will not improve their sperm count. Now, I had an interesting story of a colleague a long time ago who had a very low sperm count, like it was like less than 5,000, extraordinarily low sperm count. And the urologist put this man on HCG hormone. Now, that's really a disaster. It's not just FSH, but HCG. So that raises his testosterone level, causes his FSH to go down, and then that sperm count of 5,000 goes to zero. So putting a man on treatment can even reduce their fertility dramatically. Not just testosterone, which we know reduces their fertility, but HCG, which was commonly used, reduces the sperm count to zero, really, rather than raising the sperm count. So not only do hormonal treatments of men not improve their fertility, but they can even hurt their fertility if you do it in the wrong way. Furthermore, what if you're waiting after a varicocelectomy for the sperm count to come up for the 2 years? Meanwhile, the wife is going from age 37 to age 39. Well, you've dramatically reduced their chances of getting pregnant with IVF even. So males, be careful. I'm the expert on male fertility. I've written the book on it, really, and I'm telling you that you got to be very, very cautious about any treatment for so-called treatment for male infertility, other than zero sperm. We'll do sperm retrieval and ICSI, vasectomy or other obstruction for infections. We can do microsurgery to bypass that. We've been doing that since 1992. But in terms of trying to do any kind of treatments like varicocelectomy or hormone treatment, to try to raise the sperm count is counterproductive.
Excellent. Thank you very much for answering the questions, Dr. Silber.
Well, thank you very much, and thank you all for listening or watching on Facebook Live. And really send in your questions. We're happy. We'll keep track of them, and next time we're on Facebook Live, we'll answer those questions as well.